Most of my patients, they come in and they want to be spectacle free. So that means that most of our implants are trifocal IOLs. So we expect our patients to see well for distance, intermediate and near. The IOL material we use routinely is the hydrophobic IOL because, as you may recall, the hydrophilic IOL sometimes get calcification down the road, which is of course not favorable when you implant premium IOLs. The hydrophobic material on top of that reduces the PCO rate down the line, and of course it's not a big deal to the YAG laser capsulotomy, but still when you do premium IOL surgery and you have to do a YAG capsulotomy in 6 months of 1 year after surgery, it doesn't give a good feeling to the patient. On top of that, we want to have a glistening-free hydrophobic material, not like in the beginning the hydrophobic material is getting glistenings, which is of course not nice for the ophthalmic surgeon to see it, but also it gives a contrast sensitivity loss for the patient. The Gemetric family is divided into Gemetric and the Gemetric Plus. The Gemetric light distribution is more versus far and intermediate, while the Gemetric Plus is more, the light distribution is more focused on near. The Gemetric family is also available in the toric version, and having experience with the Vivinex, the monofocal as a toric version, I know that there is extremely good stability of that platform in the eye. So when you put the lens in the right axis, it will stay there in every case. So when correcting presbyopia, astigmatism and myopia or hyperopia with your multifocal toric IOLs, it's extremely important to hit your refractive target and also correct the astigmatism even within a quarter of a diopter of astigmatism to have the best result. The clinical outcomes of my patients with the Gemetric family are very nice so far. We were on target with our refractive outcomes, and also the patients were very satisfied. I can say that even with the glare and halos and the satisfaction of the patients are on par with the other trifocal IOLs. The Vivinex family also comes in a multi-sort preloaded injector, which is very comfortable as an ophthalmic surgeon because the nurse can prepare the lens and hand it to you, and you are sure that the lens is loaded properly, so you don't have to mingle around with it. It's also contamination free because it's already in the cartridge and ready to inject. You have the screw or you have the push, or the preference of the ophthalmic surgeon you can choose. In my opinion, every patient or every cataract eye is a good candidate for trifocal IOL implantation, unless of course they have certain degrees of macular degeneration or you find corneal scars or irregular astigmatism. There I would back off. And even in post-refractive surgery patients who develop cataracts like post-RK, post-LASIK, post-SMILE, these trifocal IOLs, they perform very, very well. Before choosing the ideal IOL for a patient, we have a lot of discussion of the lifestyle of the patient because we want to have, of course, a very satisfied patient. And as I told you, there are many patients looking for being spectacle-free down the road, and therefore trifocal IOLs are our primary IOLs which we implant. I'm fully aware that a lot of my colleagues are a little bit reluctant to use trifocal IOLs in post-refractive surgery patients. But in my opinion, those patients, they chose LASIK or PRK or RK many years ago because they're very highly motivated to get out of those glasses or contact lenses. And now 20, 25, 30 years down the road, they develop cataract or they need to, and reading glasses or distance glasses. They're very well motivated, very highly motivated to have that premium IOL, that trifocal IOLs, meaning that they are more eager to accept some more side effects like halos and glare in respect to the other general population, if I may say so.